All right. Hi, everybody. Let's see here. People are dropping in. So everybody, as you're coming into the room, please turn on your cameras. It'll really make me feel like I'm talking to live people here. If you can. If you're not driving down the freeway or something. You're in the subway. Fair enough. Okay. You're excused. Hey, Sergio, how are you? Good to see you. At the VA doesn't spring for cameras, huh? Okay, all right, Matthew, you're excused then. All right, well, let's I'm gonna share my screen here again, and we're gonna head into the first case. So okay, everybody, are you seeing that first? No, wait, you're seeing the wrong screen, I think. You're seeing, and I want to share, let's see, this one. Okay, you seeing a big screen with a ventilator screen on it? Case one, all right. Couple of thumbs up, that's what I need. All right, so let's jump into this. I'm going to just tell you about a little bit of clinical information, and then we're going to see what we can tell from this ventilator screen. All right, so this is a 65-year-old man with COVID. Everybody's seen this guy. All right, and there's no prior medical history really. Came in with COVID, progressed to respiratory failure, was intubated. He's now paralyzed. Okay, so we're not really worried here about patient effort getting in the way of interpreting what we're seeing here. So let's just talk for a minute about what we can see here and what we know. All right, so tell me whether we think, as we look at this, we've got pressure on the top, then flow and volume. Okay, so the three channels there. Everybody see where the input variables are? Somebody tell me where those are. Yeah, pointing with your finger, right? Yeah, there they are, right there. Okay, down on the bottom. Okay, and that's common, not universal, but common. And on this maquette servo eye, there are little knobs down here below each of these numbers here on the bottom row. There's a little knob right under the screen here where we can't see it. So you can actually just lift the little panel and turn those knobs, and those numbers actually just go up and down on this particular model. So then output variables are over here, right? And like I told you, sometimes those are color coded to go with the waveform. So that makes it kind of easy to tell that they're output variables and which type of which one of the three channels those numbers pertain to. All right, everybody oriented to this new ventilator? Okay, who's seen a servo eye before? Is this a familiar vent for anybody? Okay, maybe a couple. No, just as well. All right, so we'll do this on a vent you haven't seen. Okay, so tell me about the mode here. Do we think this is a volume control mode or a pressure control mode? And be careful, because words on the screen can sometimes fool you, although not so much in this case. So help me out here. How do I know this is a volume control mode or a pressure control mode? Anyone talking?
It's volume control set at 500 cc's.
And how did you tell that? You're right.
The wave, the peak of the volume time wave is the same, and the pressure is varying with every breath.
Okay, good. So one thing you can look at, you can say, well, the pressure seems to be different from breath to breath. That's one clue, although be careful, because as I told you, some modes have adaptive targeting schemes, right? And so sometimes the control variable can change from breath to breath. So be careful with that. I think the very best way to tell if a mode is volume or pressure control is to look at the flow channel, okay? So that's this one, that's the green one, okay? And if you see a razor straight line on flow, that tells you the monkey is locking in the flow, all right? So let me just draw on this here for a second, okay? Everybody sees this straight line, right? My pen's working here, okay? See how straight that is? Straighter than the line I drew, okay? If you see that straight across line, that means there's a constant flow. If flow is locked, so is volume, okay? Remember, they're on the same side of the equation, but pressure would be the dependent variable, all right? So that's one thing, but you gotta be careful because sometimes the flow isn't locked at a particular value. Sometimes this is a square wave, but sometimes there's a decelerating wave like this, right? So don't be fooled just because it's not, you know, horizontal. It could still be, if this is a totally straight line, that's still probably a volume control mode when the monkey's giving you a straight line for flow here, okay? The way that I think you can think about this is if you think about exhalation, okay? So here's the flow channel here. Any inward flow is above the line, outward flow is below the line. So exhalation is always down here, right? Everybody with me? And in almost every case, nearly every single mode, and there's like 200 modes, exhalation is a passive pressure control phenomenon, all right? The monkey just opens the valve and the pressure in the chest just pushes the flow of air out through the ET tube out into the world, okay? And so when the pressure difference is greatest, the flow is greatest. And as that pressure drops within the chest, as the air goes out, that pressure decreases and so does the flow. And it doesn't increase in a straight line, it decreases as an exponential decay function, right? And so you see this nice curve going down to zero flow. Here's a nice one over here, okay? See that, how it just decreases in that nice curve? So that's what a pressure control flow looks like. Remember that exhalation is nearly always pressure control. So if you ever see a curve that looks like this, but flipped up on top of the line, so if you look up here and you see a curve that looks like this, you know that this is a pressure control mode because this is following the same pattern as pressure control exhalation. Does that help? Okay. Now, it doesn't always get to zero because usually inspiration's too short for those pressures to equalize. So a lot of times, if you've got a pressure control inspiratory pattern, this will go up to a peak inspiratory flow and then it will come down and it will end up, you know, somewhere above zero flow before at the end of the breath. But you'll be able to see that it's not a straight line, that it's a curved exponential line. Okay, making sense? So it helps us, of course, that it says it's volume control up here. Okay, but be careful because some modes like, you know, pressure regulated volume control is actually a pressure control mode. And so they do mean things like that to you, just to fool you. Okay, so we've talked about square waveform. We've talked about decelerating waveform. We figured out where our variables are. Let's move on and find out a little bit more about this patient here. Okay. Okay, so here's our patient paralyzed on the ventilator with COVID, pneumonia, and ARDS, and we get a blood gas, and the pH is 7.32, CO2 is 65, PaO2 of 50. Okay. Tell me if you're happy and tell me what you're happy about and what you might not be happy about. Come on, guys.
Be concerned about the PCO2 being a little bit higher than what you want it to be and the PaO2 being a little lower than what you want it to be.
Okay, great. So PCO2 is definitely higher than normal. PaO2 is definitely lower than desirable. How's that? Okay, way lower than normal. Okay, which one of these is a bigger problem?
The PO2.
The PO2, right. What's the range that we want our PO2 to be in? You know what the guidelines say?
80 and above.
100.
85 to 80.
85 to 80.
Good. Somebody said 55 to 80 is what most of the guidelines say. 55 would be the minimum we'd be happy with, right? That generally corresponds with somewhere around 88% sat, right? A little higher than that might make us feel a little bit better about things, but at least 55. So 50 is not enough. Okay. So let's focus for a bit on oxygenation, because this is ARDS after all, right? And oxygenation is usually the challenge. What are the things we can adjust on a ventilator to improve oxygenation?
PEEP and FiO2.
PEEP and FiO2. Love that answer. That is basically the right answer. Besides, one quick finer point, what you can actually adjust is mean airway pressure and FiO2. PEEP is by far the most common and easiest way to change mean airway pressure, but there are other ways, okay? So just tuck that away somewhere, and as you get into fancier modes, you will occasionally use other ways of increasing mean airway pressure. But for our purposes, PEEP and FiO2, perfect, okay? So what would you want to do? Looking at those vent settings, would you want to change either the PEEP or the FiO2 or both? And how would you think about that?
So I think looking at the peak airway pressure sitting at about 33, which is already a little bit on the higher side for volume control mode. And you know that you're already dealing with what I'm assuming 500 for this person is likely particularly lung protective. And so ideally for ours in our protocol, you'd want to go up on the PEEP, but you probably want to make sure your driving pressure isn't changing too much. Otherwise, you could just make an adjustment to the FiO2 and see if that shifts things in a more favorable direction.
All right, great answer. A lot to unpack in there. If you didn't follow everything he said, don't worry, that's okay. But I like that. I like that. Let's talk for just a minute about PEEP. So you're saying that, you know, ideally what you'd like to do is adjust the PEEP here. Let's talk about what PEEP does, okay? So here's a little schematic, a couple of alveoli, one of them aerated, the other one not aerated, either because it's atelectatic, okay, collapsed or full of fluid or something, okay? And what we're seeing here is how blood flow through those alveolar capillaries is only going to pick up oxygen if it's going through an aerated capillary bed, right? The other blood flow going through the atelectatic part of the lung is going to be shunted. Okay, so it's not going to pick up any oxygen. And so when it mixes with the oxygenated blood, the overall blood flow going back to the heart via the pulmonary veins is going to have less than full oxygenation. Okay, that's not good if you've got somebody sick with COVID. And you know, this is the primary mechanism of poor gas exchange in ARDS, right? So what's PEEP going to do for us here?
It's going to open up the ventilated alveoli.
Okay, good. So that pressure is going to come down here like this, right? And hopefully kind of pop that thing open, right? So that there's air in there. Anything else it does? Like right here?
Prevent collapse at the end of expiration.
Good. So, okay, great. Yeah, we'll get to that too. That's right. It's going to prevent that alveolus from collapsing again when we get to the end of expiration. The other thing it's going to do is it's going to push interstitial edema out of here, right? To make that alveolar membrane more permeable, you know, a little thinner for better gas exchange. So PEEP is a good thing for oxygenation, okay? Again, as a way of increasing the mean airway pressure, okay? The other thing about PEEP, and you alluded to this just now, is that it will move us from this flat part of the lung compliance curve where we think the alveoli are collapsing at the end of each breath because they're destabilized in the ARDS milieu, right? Because the surfactants all disrupted and everything. So we don't want that. We don't want those alveoli collapsing and popping open, collapsing and popping open. They're pretty fragile as we know. And so all those shear forces damage the tissue and lead to worse and worse gas exchange. And ARDS is many, many times an iatrogenic disease, right? That we cause by our ventilator. We also don't want our pressure to be too high where we're over distending the alveoli like you would imagine happening up here at this part of the curve. We want to be here on the sweet spot of the curve, right here where the slope is steep. So little changes in pressure lead to larger changes in volume. That's the definition of good compliance, right, in the lung, or low elastance, okay? So PEEP is going to move us from this zone up into this zone, we hope. And if we get it right, we won't overshoot and end up here in the top part of the curve, okay? Now, there are about 10 ways to pick the right level of PEEP for your patient, which tells you what? None of them's any good, right? Otherwise, there would be one way that we would use every time, all right? And I actually think that some of the ways that we use are better for some situations than others, all right? And so it's kind of good to know a few ways, but when you look at all the studies, especially the big, multi-center trials like ARDSNet conducted and all these, trials of mechanical ventilation, the simplest and most reproducible way to set PEEP consistently was to use a PEEP table like this. And so there's this low PEEP table up here, okay? And then the higher PEEP table down here. Some places never use the higher PEEP table. I will tell you, sometimes we do use it here in Cleveland. Sometimes we use the lower PEEP table. It kind of depends on the scenario. But if you find our patient, okay, here's our patient right here, okay, with 40% FiO2 and 5 of PEEP, okay? If we were gonna move up according to the table, we would first increase the PEEP to 8, okay? If we were following the table as a kind of a protocol. If we still needed better oxygenation, the next step would be to increase the FiO2 to 50%. Everybody see that? How you do that? And we would keep going. Next, we would raise the PEEP to 10, FiO2 to 60%, but then the next step, we would raise the FiO2 to 70%. So it's not always back and forth. It just depends on the table, okay? And likewise, if we were using the high PEEP table, by the time we're at 40%, this table says we should be at 14 of PEEP. So we'd be moving up on our PEEP here pretty quickly. All right. So we're going to use PEEP and FiO2 to adjust our PaO2. So we do that. We use our little knob at the bottom and we turn the PEEP from 5 to 10. Everybody see that red circle sign there? Okay. What else has changed? We moved our PEEP up. What's new? What's different?
Mean airway pressure.
Good. The peak airway pressure went up from 33 to 36. Is that a surprise? Is it good? Is it bad? Not a surprise. Shaking heads, no. Okay, I agree. It's not a surprise. Now we raised the PEEP by 5, but the peak airway pressure only went up by 3. Is that good or bad?
That's good.
It's actually good, right? That means that we've improved the compliance. Okay, so that the same volume of air going in gave us a smaller pressure change than it was before. So we probably got some of our alveoli out of that flat part at the bottom of the curve and onto the steep part of the curve. That makes sense? Okay, that's something that, maybe you chew on for a little bit, but that's an important concept, okay? So this PEEP change was probably a really good thing, but what else?
Your volume has dropped?
Volume, not my, so our tidal volume is still 500. So we didn't change that. And the minute volume hasn't really changed. It's 9.7, 9.8, still roughly the same.
The plateau pressure. We need to
Okay,
check.
so what is the plateau pressure? That's a great thing, right? So let me show you something real quick here. Okay, remember going back to our waveforms, here's the square waveform of flow. If you can hallucinate with me, can you see a little jump in the pressure right there before it starts to go? If you can see it better here, maybe. It goes straight up and then it goes up at an angle and then it drops down at the end of the breath. What's this little straight up part? Remember the equation of motion? Two components combine to give you this pressure. Okay, actually 3, right? Because you've got the PEEP right here. Then you've got this component and then this component. This is the flow resistance component right here. And this is the volume compliance or volume elastance component, okay? So as soon as the flow starts, there's immediately pressure. That's because there's resistance in the tubing and that pressure is immediate. So it goes straight up, okay? And then as we add volume, that volume elastance component kicks in and we reach our peak pressure. If this component is the same at the beginning of the breath as at the end of the breath, we should see it right here when we check a plateau. You with me? Everybody with me, more or less? Okay. So maybe we should do that, okay? Let's see here, okay. Oh no, we only got 2 minutes. Okay, so what we're gonna do when we check a plateau is we're gonna get rid of that resistance and flow component by stopping all the flow, right? So whichever vent we're using, we're gonna stop the flow. And then we see that pressure plateau out here, 0 flow, see no exhalation. The volume's still in the lung. And here's the plateau pressure, and it comes out to 34. Okay, so our plateau, our peak is 37, our plateau is 34. Are we happy with that? No, we're not, right? So what are we going to do?
Lower down the PEEP.
We can lower the PEEP, or because we think the PEEP was good, right? The PEEP got us out of here. Okay. But
so we could reduce the tidal volume and just deal with it.
Excellent. Okay, good. So remember, there's a couple other things we can do. We got out of the atollic trauma zone by increasing the PEEP. We can get out of the volume trauma zone by decreasing the tidal volume. Okay, so let's do that. And we take our tidal volume down to 400. And now look, our plateau is 29. We happier with that? Yeah, we are, right? What else changed?
The minute ventilation dropped.
Good, the minute ventilation dropped. Are we surprised? No,
Nope.
Because minute ventilation is tidal volume times respiratory rate, right? Respiratory rate didn't change, but the tidal volume went down, so the minute volume went down. Is that going to be okay? Well, he's already acidemic with a high CO2, so we're going to have to watch that pretty closely, right? What if he comes back too acidemic? What if he comes back 7.12? Then what do we have to do?
And increase the rate.
I think Dr. Ashton got pulled away. We're going to get a new instructor. So you're going to have to ask him the answer when we return back to the main room. Yeah, he said moving the facilitators now. No need to leave the room. So we'll get a new one.
Hey, everybody. Are you guys there? Oh, perfect. We got one. Wow, Chris, you're pretty dedicated. That's pretty awesome. Calling on your drive home today, huh?
I'm in the passenger seat. Don't worry.
That's good. I saw that. All right. So now that you got ARDS under your belt, let's see which. You're seeing my display settings, aren't you? I mean, my presenter view, aren't you? Or
We aren't seeing anything.
Yeah, we
Actually, I
can't-
don't have a screen yet.
Yeah, we can't see anything.
yeah. Hold on a second. 2 years of trying, I'm getting it. There we go. All right, give me a sec. Okay. All right, now we're on. So now that you got ARDS down, we're going to go to the hard stuff. Now, I'll tell you that I think for me anyway, the scariest moments of my career have come when I've had an uncontrolled asthma patient. And the reality is because everybody likes to talk about how difficult ARDS is to ventilate, and I know through the pandemic that every single one of you has probably had an opportunity to manage a ventilator on an ARDS patient, but the truth is that asthma I still think is much more difficult and vexing. So we have this patient here. He comes in, 35-year-old guy, ARDS. This is his ventilator, okay? And what I want to ask you is, if you look at the waveforms and you look at the pressures, remember this is the input variables over here. So let's see, put my pen on. So here's the input variables, right? Over down here. So what mode do we have this guy on? What's the monkey responsible for? How about Santosh? Santosh
Volume.
pulled over, Chris.
Volume.
So volume, good, volume control. Now, if Santosh, I don't know if you just looked up here or whether you said that because you saw the control variables, but you're absolutely right. So
Yeah, the sine wave pattern kind of that was alluded to the last point.
perfect. Perfect. So yeah, you could look at the waveforms. We didn't go into those, but these don't look very responsive to something else. And so you're absolutely right. This is volume control. That means we're telling the monkey, right, to control the volume. So we enter that in the flow, which you can't see here, okay? And the monkey on the back end, or the physiology of the patient, is going to dictate the pressure at the mouth, okay? Now, there's a couple of variables that suggest that trouble is on the horizon with this patient. The first is that if you look at the peak pressure, it's a little bit high. So you're probably going to have a respiratory therapist coming to you pretty soon saying the peak pressure is high, okay? And when you go in the room to investigate, you should notice this expiration, right? And you go, oh, expiration, they didn't talk about that in ARDS. But what's notable about expiration, and I'm going to focus you right here. What's going on right at the end of that breath, or what's not happening?
Waveform give us this flat
retaining, it's out
like the flow is constant. So that also tells.
Yeah, exactly. So the flow is not going back down to zero. So if it was going to zero, right, the flow should come down and it should go kind of like this, okay, in a normal person. But you can see right before the next breath, this guy is still breathing out. And that's a problem because that means that this guy's still trying to exhale and the next breath is triggered. Now I'm going to point you to the fact that this guy's breathing 24 breaths a minute, right? So let's talk about what we do here. So we said that we get to control this side of the equation, right? The volume and the flow, and that the patient's physiology, depending on their elastance and their resistance, gets to control the pressure of the ventilator, okay? Now, how might we figure out, remember I said that peak pressure was 35. You see this? 35. So how would we figure out what component of that 35 centimeters of water is related to the elastic pressure and what component is related to the resistive pressure? Can we separate those two? How might we figure that out? You guys just did it in your last case, right?
Calculating the
Plateau.
difference between
Plateau
PEEP
pressure.
and PEEP Plateau.
Say it again, Sergio.
Oh, sorry. Calculating the difference between the peak pressure and the plateau pressure.
Good. So the plateau pressure. So we're going to measure the plateau pressure, right? Which cancels out the resistance. So we lock the pressure. I mean, we lock the ventilator at the end of inspiration, like you did in your ARDS case. And all we're left with is the elastance. And in this patient, right, with asthma, the elastance should be pretty normal. And so in fact, actually, the respiratory therapist says, hey, I did a plateau pressure, and their plateau pressure was 14, okay? So that means that there's 20 centimeters of water, right, of resistance now, You go, oh man, that's a lot of resistance, right? In a normal person, if I put you on a ventilator, your resistance would be like 1 centimeter or 2 centimeters of water, okay? So the question is what might cause that resistive pressure to go up? Anyone have any ideas?
Bronchospasm.
Okay, so bronchospasm, the obvious thing, I mean, we got an asthma patient here, right? So bronchospasm, because those airways, the small airways are collapsing and they're limiting flow out. But before we blame it all on bronchospasm, what else do we have to think about? What else might be?
Patient biting the tube.
Patient biting the tube. So if you think about, say that again?
Secretions.
Secretions as
yeah.
well.
So if this is the ventilator, you'll notice on all the ventilators that there's 2 tubes, okay? There's like a white and a blue one, and then here's your ET tube, and here's your patient, okay? And so the flow is going through the tubes like this, back to your ventilator, okay? And the sensor for the ventilator, which is measuring the pressure, is not at the patient's mouth. It's actually right on the return port at the ventilator. So if you have a kink in any of these tubes here, or at the ET tube going into the patient's mouth, you're going to have an increased resistance to flow that's picked up by the ventilator, okay? So secretions in the tube, patient biting on the tube, you're leaning against the bed and you're crushing the tube against the bed. You're somebody stepping on the tube. In COVID, we had these big long hoses going out the door, right? And so maybe the patient's crushing the tube, or you're crushing the tube because you're stepping on it. Any of that stuff can increase the resistance. But if you've rooted that out, then you need to start thinking, oh, what's going on with the patient? Maybe there's something going on with the patient and I've got a high resistance due to their intrinsic airways, okay? And so how might we be able to evaluate that? Well, if you remember, I showed you that at the end of this patient's breath, right? You see right here, I told you that that patient was still breathing out. Now let's talk a little bit more about this, because what we call this is dynamic hyperinflation, okay? And what we're trying to figure out is there dynamic hyperinflation? Another word for this is air trapping, or is there just simply high resistance? And let me explain the concept a little bit. So dynamic hyperinflation and air trapping leads to something called auto-PEEP. And auto-PEEP is important to recognize because if you think about a normal person, right, they should have, so as you breathe out, when you fully inspire, the pressure in your lungs is higher than the pressure at the interface between your mouth and the atmosphere. And so naturally, the elastic recoil of your lungs and your chest wall is going to push air out until such a time that the pressure of air in your lungs and the pressure at your mouth are in equilibrium, right? Everybody agree? And then you'll have zero flow. So here, if there's still flow out, that by default means that the pressure inside the lungs is still higher than the pressure at the mouth. And if there's an obstruction, right, limiting how fast airflow might come out, then that's going to increase the time which this equilibrium, increase the time which it takes to achieve this equilibrium. And so if the breath is not long enough to get to that equilibrium, i.e. the ventilator triggers before that time, then you're going to have still some air left in here when the next breath goes in. Now I want you to do a little bit of a conceptual maneuver, okay? Take a deep breath in. Now breathe only 50% out. Take another breath, only breathe 50% of that out. Pretty soon you realize, like, it doesn't take a lot of breaths to feel like you just can't breathe anymore. And that's what happens with dynamic hyperinflation or air trapping, okay? Is that the patient's lungs starts to build up flow until the lung either pops or you disconnect them or something else occurs, okay? And so this concept can be actually pretty dangerous. Why? Because if the lung gets super overexpanded, what's that going to do to the pleural space and the inferior vena cava and superior vena cava going through it, right? It's going to start to crush that, and you're going to develop decreased venous return. Next alarm you start to hear, right, is the low blood pressure alarm, and then the code alarm as this patient just expands. Or if they have a pneumothorax, you're going to end up with the tension pneumothorax and hypoxia and low blood pressure. So this is a pretty problematic thing. And the way that we can check this out, okay, is by doing something called an expiratory hold. Now, an expiratory hold is similar to an inspiratory hold. In essence, what we're going to do here is we're going to let the patient breathe out, and right at the end of their breath, we're going to lock this. And you see down here on the Maquette Servo I, there's an expiratory hold button. So right before inspiration, it locks it. No inspiratory or expiratory flow here, okay? And we can measure the pressure just like we did with an inspiratory hold, except for at the end. Now, if the patient's at equilibrium, right, that means that their pressure on this expiratory hold should equal the PEEP, the end expiratory pressure that we're giving them. But if the patient's not at equilibrium, their end expiratory pressure should be higher than that PEEP, right? Because their lung is still partially inflated. And if you look at our patient here, we gave them a PEEP of 5, but at this end expiratory hold right here, look at what their PEEP is measuring at, 22. So that means that their lung is still pretty inflated, right? And they've got dynamic hyperinflation, which means that they haven't fully exhaled their breath. And this is going to continue, and this auto PEEP will continue until the patient either codes, develops a pneumothorax, or you figure it out. Okay, so for more on auto PEEP, you can scan here. I put a primer in the wiki for you, Ren and I made, and so you can look at that. This is a good best of ATS video lecture series if you're interested as well, okay? These slides will also, I think, be on the wiki, so you can check this out later. Now, how might we fix auto PEEP? What do you guys think?
Decrease the rate or decrease the inspiratory time.
Good. Decrease the rate or decrease the inspiratory time. So what you can see here, right, is that the rate, if you have a patient who's on the control variable is the rate, right? So that means that a rate of 12 means that from the beginning of one breath to the beginning of the next breath, we're going to have approximately 5 seconds, right? Because it will not allow you to take less than 12 breaths. So even if I paralyze the patient, if I give them 12 breaths a minute, I'm going to have a maximum of 5 seconds between breaths. At 24 breaths, we had little less than 3 seconds between breaths. That's what we originally started on back here. Remember, 24, okay? So you can see the time here between the beginning of one breath and the beginning of the next breath is pretty short compared to this time. How much different is the inspiratory time here? Did we change the inspiratory time at all? We did not, okay? The only way to change the inspiratory time is to change the I to E ratio or the flow rate, okay? And I'm not going to go into that, but that's another way. So we could, I heard someone say, shorten the inspiratory time. So we could change shorten the amount of time that it takes to get this full breath in, okay? But which one do you think is going to be more effective? Shortening the breath in or lengthening the entire duration of the breath?
Duration of the breath.
Yeah, of course, by a lot, right? Because here you can see there's not a whole lot of change that we can affect. I mean, you gotta give some time for the breath to go in. But if we increase the amount of time if we decrease the number of breaths per minute, we increase the amount of time that this patient can breathe out. Now, there's one problem with this. If we keep our tidal volume the same and we decrease the respiratory rate, what's going to happen? We are going to drop our overall minute ventilation. And that can be a problem, right? How might we fix this? So we can fix it by increasing the tidal volume. So this is the one situation where, you know, in ARDS, you want to have low tidal volume. This is the one situation in which having a higher tidal volume might help you, because you can decrease your respiratory rate without changing your minute ventilation, okay? So the keys in asthma are decrease your respiratory rate, decrease your inspiratory